refers to various retinal manifestations seen after a febrile episode due to direct invasion of the pathogen or immune-modulated mechanisms in an immunocompetent person, usually seen 2 to 4 weeks after fever. It is characterized by diminution of vision, which is sudden in onset and painless. It could be unilateral, but mostly bilateral. So on fundus examinations, we can see multiple patches of yellowish-white lesions scattered throughout the fundus. These lesions can range up to 3 disc diameter in size and bright white in color when compared to cotton wool spots, which are smaller and are dull in color. We can see venous bleeding, vascular tortuosity, hemorrhages, and perivascular sheathing. Optic disc involvement may or may not be there. Macula can present with serous detachment or macular edema. Another interesting finding which we found in our patients were telangiectatic vessels, which can be seen around the disc as highlighted on fundus fluorescent angiography or around the peripheral arcades, which responded very well to intravitreal triamcinolone injections in our patients. So for diagnosing this entity, we need to take a detailed history of fever, travel, rule out diabetes, hypertension, perform baseline blood investigations, do serological tests for diagnosing a specific entity of infection, do detailed fundus examination, fundus fluorescent angiography and OCT as needed. On fundus fluorescent angiography, retinitis lesions typically present as hypofluorescent lesions with perilesional hyperfluorescence. Vascular changes in the form of staining, beading and dilatation may be seen. Now I would like to focus your attention to this optical coherence tomography of the patient, in which we can see hyperreflective dots in the vitreous which are suggestive of vitritis. Retinitis patches typically present as hyperreflective areas with backshadowing and distortion of inner retinal layers. There can be intraretinal fluid or subretinal fluid causing neurosensory detachment at macula. Hyperreflective dots along the RPE or outer plexiform layer suggestive of hard exudate may be seen. So I would again like to draw your attention to retinitis post-febrile illness, in which clinical features are similar, although the etiology of fever is different in different cases. The features include retinitis lesions, which are yellowish-white lesions scattered throughout the posterior pole, vascular changes in the form of hemorrhages, vascular wall dilatation, telangiectatic vessels. On fundus fluorescent angiography, we see retinitis patches as hypofluorescent patches with hyperfluorescent margins. OCT can demonstrate hyperreflectivity due to retinitis patches. It may also show neurosensory detachment at macula. So we can differentiate these retinitis lesions from cotton wool spots based upon their size and color. Also rule out other etiologies like hypertensive retinopathy and infectious retinitis before diagnosing a case of retinitis post-febrile illness. So now I would like to leave you with a thought to ponder upon. Since this retinitis post-febrile illness is caused due to an infectious etiology, can it show seasonal variation? Thank you for your kind attention. Goodbye. Until next time we meet again.